respected Chairman, Dr. Pranab Kumar Basu sir, moderator of the session, Dr. Babu sir, and all the dignitaries, delegates, students, and dear friends. I'm actually really honored to be here to deliver not my view, the views of Ayurveda in mitigating the main symptoms in palliative care, like pain, sleep disorders, and anorexia. So, from the bottom of my heart, I thank Dr. Babu sir for inviting me, Dr. Nimimol madam for giving me this chance. So, I'm not going into detail about the palliative care because we don't have much time. I'll definitely try to stick on to 20 minutes. So, I'll straight away go into my topic. Actually, I was fortunate enough to work with the Institute of Palliative Medicine for the last more than 15 years. So, as the earlier speaker, Madam told, Madam have already defined the pain. Actually, this is the new definition of pain, where I need to focus only 2 points. One is resembling that, and the second phrase is associated with, which means that for a person to experience pain, it is not mandatory to have a damage. It is not mandatory for the patient to get a damage for a person to experience or express his pain, because it is not only sensory, it is emotional, it is psychological. And when a person says it hurts, it means that the patient is in pain. So when a person says it hurts, it means that he's in pain. No matter, you are not a person to assess how much damage has happened. You may think that this is only a small problem, small issue, but still, if a person says it hurts, you have to consider that, you have to respect that person, that feel. And Ayurveda has, in different contexts, we have in Ayurveda, the definition of pain or pain has been, the synonym of pain has been the same with the synonym of disease. So Ayurveda defined pain as Rujanti Roga Deha Manasi Sandhavayandi Ityarthaha, which means that every pain is having a biopsychosocial component attached to it. That is a very important point which the students have to understand. Every pain will have a biological, psychological, and a social component attached to it. And pain is always a personal experience. It is influenced by, to varying degrees, by biological, psychological, and social factors. The way you experience a pain, the way you express a pain will be different in different social contexts, right? It will be different among the different people having different financial background, people having different social context. Like, so it's always a personal experience, and this is very important. Pain and nociception are two different phenomena. That was what Dr. Abhijit was telling. Pain and nociception are two different phenomena, and pain cannot be inferred solely from the activity in sensory nerve. Pain is beyond nociception. That is what we have to understand. And through the life experience, individuals learn the concept of pain through their life experiences. So the life experience of each one of us will be different. Each of the patient will be different. So that is how they learn the concept of pain. And a person's report of pain, a person's report of an experience. A person's report of an experience as pain should be respected. And many times this acute pain may have some benefit, right? Do you agree? Acute pain may have some benefit, but definitely chronic pain doesn't have any benefit. It will have an adverse effect on the function, the social and psychological well-being of the patient. And many times we rely upon the verbal description, verbal communication only. But that is not true. What I have seen is that more than 70% of the patient in palliative wards will be finding difficult to verbally express how much pain they are undergoing. So as a student, always you have to learn to understand the patient non-verbally also, not the verbal, non-verbally also. And this is very important, especially in pediatric cases, especially in old age cases. So the prime duty of a physician, according to Ayurveda, is to address the pain and try to alleviate the pain. I'm not telling it is 100% you can alleviate every pain. No, no medicine can do that. At least address the feel pain. Address the feel pain. Vedanayascha nigraha. It's called Vyadhyas Tattva Vedanayascha nigraha was the prime duty of the physician. And one more thing is that Vaidyatam na Vaidya Prabhurayasha is told. The second line. I'm not going into the Sanskrit things and all. Na Vaidya Prabhurayasha means you shouldn't think that you are beyond everyone. You don't have such an ego. You are no one. As a doctor, you have to understand the fact that we are not the supreme powers. So we have to have that compassion as Dr. Abhijit had earlier told. And this thing, the pain is divided into nociceptive, neuropathic, and again into visceral and somatic. So what we do is, in Ayurveda, 46 types of pain are explained in different contexts. So why these different terminologies are explained? In modern texts, we see burning type of pain, pricking type of pain, different types of pain are explained, right? Likewise, in Ayurveda, 46 types of pains are explained, like plosham, chosham, mushti dandahadopamam, piviliga, different types of pain are explained. So this helps actually to understand the site of the pain, the character, onset and all. So in a community, in a doctor community, in a physician community, it is easier if we come into consciousness about the different terminologies. So if you know the terminologies, we can understand where exactly the site is, what is the character of the pain, how severe is the pain. And dosha dushya is something unique to Ayurveda, which is considering which dosha, vada, pitta, kapha, which dosha is predominant, which dhatu is predominant. So it is unique to Ayurveda. And so we can plan the treatment, and it points towards the diagnosis, and we can plan the correct treatment by knowing the terminologies. So in palliative sector, in palliative wards, what we generally give for the visceral pain is Dhanandaram Guliga, Churiya Antragutaram Guliga, drugs like Parushadi Leham, Ponkaradi Guliga and all. These are drugs which we generally give. Certain drugs like Udajarishtam, Hingujadi, Chandraprabha. So we have conducted so many surveys, we have conducted so many researches also, and from that we have concluded, and this is what we are giving in the palliative care. And one thing is the cannabis infused medicines. In many countries, still we are we are against the concept of using this cannabis. But medicinal cannabis is something which is coming up everywhere in the world. In many Southeast Asian countries, many European countries, in some states in US and all, they are promoting this. They are conducting researches in the cannabis infused medication. So I think this is one area where we all can look into, and we all can try to conduct some researches. Medicinal cannabis, not the recreation one. So as Sadishan sir had told, there is a compliance issue while taking this Ayurvedic drugs. So there are other methods also without giving internal medication, which we do for the patients who definitely will have the complaints to take the internal medication. One is the type of fermentation, that is Pradeshika Svedanam. Avagaham is a type of Siddhbath and all. Matra Vastis are giving medicines through the rectal route. So those who can't take the medicines internally by mouth, you can give the medicines through the rectal route, and Varti also through the rectal route. And for the somatic pain, there are many drugs like Ugritam Yoga, Bharanyadika Shayam, Yograjam, Rasa Sinduram, and one medicine, Rasa Gandhi medical, which we have taken from the Siddha medicine. Siddha medicine, doctor will agree with that. I learned from the Siddha medicine doctor. It's a very effective medicine. The Rasa Gandhi medical, it's actually given in the afternoon, I think. Yeah. So that is what we give. And again, the non-pharmacological treatments like Pradeshika Svedanam, like external application of the medicines, bandages and all, these all things we do. And for the neuropathic pain also, there are drugs, Vairyadi Kashayam, Idaryadi, Prasaranyadi, Sahasradi, Durgundi and all. And these medicines, I want to focus on these medicines, the Vada Gajangushara Sambhrat, Vada Chintamani, these are not purely herbal medicines. These are herbo-mineral medicines, which many of the doctors will be finding it difficult to digest because minerals can be toxic, right? But all these medicines are being studied, are being researched, published for their toxicity and for the effectiveness. So these are very safe medicines. We have been giving these medicines for a very long period. These are in the old text, and also we are giving it for many years. So there is no toxicity. Don't worry about this thing. Again, here also we use the cannabis infused medication. So what exactly is the role of Ayurveda? We are not telling that only with Ayurveda we can mitigate the pain. We are not telling that. Many a times it acts as an adjuvant. As the earlier speaker rightly told, we need some adjuvant, right? So many a times these medicines act as an adjuvant to limit the side effects of NSAIDs. As you know, NSAIDs will have side effects like gastric issues, liver toxicity, renal toxicity. So giving an Ayurvedic medicine, appropriate Ayurvedic medicine along with these NSAIDs will help to reduce the side effects of the NSAIDs. It acts as a co-analgesic also. As the madam told, there's a WHO ladder, right? So once you start with NSAID, if the NSAID is not working, you go to the weak opioid and then to the strong opioids. So along with the NSAIDs, you can give the paracetamol, right? You can give the paracetamol, but no two NSAIDs should be mixed together. Okay, so if a patient doesn't respond to an NSAID, either you can combine with paracetamol, and some patients even doesn't respond to that combination also. So when we give the Ayurvedic medicines along with the NSAIDs, the patient is finding much relief. So you can give this Ayurvedic drugs or any other homeo drugs, Siddha, Unani and all as an adjuvant, which I think will definitely help the patient. It can be given as an antiemetic, especially for the patient who is on morphine, can develop vomiting. So as an antiemetic you can give. As a laxative you can give. There is a study conducted in Institute of Palliative Medicine in association with Kottakal Ayurveda in the morphine-induced constipation, and it has been published in the PubMed Index journal. The use of this Mishraga Sneham, the study was conducted in 1998, I think. So it has been found to be very effective in mitigating the constipation, the morphine-induced constipation. And there are other medicines like Brihatrabala, Virejana Gulika and all, Abhayanayaki and all, which we give for the patients who is having constipation due to the morphine. And for nausea and vomiting, we give medicines in a small doses in frequent time. So drugs like Nayobayam, Dhanantaram and all we give. Next is the sleep issue. These are the common sleep disorders which we see in the palliative ward. Insomnia, sleep apnea, restless leg syndrome, circadian rhythm sleep-wake disorder, hypersomnia, parasomnia, again not very common, but still it can happen. Sleep disturbance due to delirium. So, multifactorial in nature, driven by combination of disease process, treatments like chemotherapy and all, and psychosocial factors. And there are actually certain disease-specific patterns which we can see in the ward. So this is something which we generally see in cancer patients. More insomnia and parasomnia are seen mainly due to pain, the effect of chemotherapy and the fatigueness. And for neurological disorders like motor neuron disease or Parkinson's disease, the restless leg syndrome, sleep apnea are commonly seen. In heart failure and COPD, sleep apnea is very commonly seen. Insomnia is seen. And in dementia patient, most often you see the circadian rhythm disorder and the delirium related sleep issues. These are very common. And the Ayurvedic approach towards mitigating the sleep issue is not just confined to the pharmacological. We emphasize on using non-pharmacological methods more than the medicines to induce the sleep, like Sattvavajaya therapy, which is something which we extensively study nowadays in Ayurveda. This is something like a psychological counseling, something like not exactly a counseling, but something like a psychological counseling. So, in a structured way, in a structured format, we do the Sattvavajaya therapy, which generally helps, especially insomnia patient and patient having this RLSN. So Ayurvedic massages, a certain type of massages which is not very strong massages, not the routine thing, that also generally helps. psychological support, and definitely sleep hygiene is important. And the pharmacological use depends on the cause. I have 5 minutes, right? So pharmacological use depends on the cause, and there also we try to do external therapies like talam, which is keeping the medicines on the bregma, on the forehead and all. Drugs like Himasagara, Thailam, Panchagandham, which is very effective. In the evening time, we get 5 o'clock and 5:30. We keep it for 30 minutes or maximum 1 hour, and the patient gets good sleep. And judicious use of Ayurvedic sedatives. I don't like to term it as a sedative, but some Ayurvedic drugs like Yashti Churnam, Ashwagandha Churnam, Sarpagandha, these medicines are having very good effect. And medicine, if the patient is having RLS, medicine should be given for that. And symptom control is very important, addressing pain, dyspnea, nausea. Not only this, sometimes a patient may not be sleeping because of bugs. In the ward, there will be bugs. So you have to probe deep into the cause of insomnia, why this patient is not sleeping. The patient may have ants, the bed will have ants, bugs and all. So you have to go deep into that and try to identify the cause why he is not sleeping. And psychological support is important. Proper reassurance is always better than giving false hope. As a student, you have to understand, don't give false hopes. You just reassure the patient. Patient will understand. By the time he goes through the disease process, he will have an idea better than us. So proper reassurance is always better than giving false hope. Next main problem is the anorexia, the problem with the loss of appetite and all. It's a very common and distressing symptom. Many times we undervalue this symptom, anorexia. When if a 60-year-old woman tell, I don't have appetite, you tell, okay, that's fine. But anorexia is always a distressing thing. It contributes to weight loss, weakness, and reduced quality of life. A complex interplay of psychological, psychosocial, social, treatment-related factors and all are related. We term it as aruchi. In Ayurveda, we term it as aruchi. Basically, the problem is with the digestive capacity, which we call as Agni, digestive capacity. The metabolism is all coming down, and it is always, I've seen in many patients, I've seen this loss of appetite as the most single important symptom in their terminal phase of life. During their last days, many patients will develop this loss of appetite, not having interest to eat. So if you see a patient in the palliative ward getting this loss of appetite, you have to be careful. Then disease-related factors underlying illness like cancer, release cytokines inducing cachexia. It directly impair appetite through obstruction or metabolic changes. And we, as an Ayurvedic physician, we focus on relieving the amam, which was just something like endogenous toxins produced in the body, which helps to improve the digestion, and medicines for Agni Devana to improve the digestion, like Vishwamritam, again a drug which is studied in Institute of Palliative Medicine in Calicut Medical College. It's also a medicine which is studied in IPM, Vishwamritam. Again, some patients had compliance due to the gastric problem, but most of the patients tolerated it well. So if your patient tolerated well, it's a very good medicine to give for an anorexia patient, Ashtachurnam. And Gavyam, more often we give in the obstruction cases. In dysphagia, in obstructive cases, we give this Gavyam. Again, organ failure, again, cause more endogenous toxins, which we call as Visha Amam. Altered Agni is there, a fluid overload. These all causes a loss of appetite. And neurological conditions common in dementia. It's very common in dementia, brain metastasis, Parkinson's patient to develop loss of appetite, affecting appetite regulating center, and can be due to dysphagia. Again, metabolic and hormonal changes, gastrointestinal dysfunction, like mucositis, esophagitis. This will contribute to altered anorexia, constipation. Medication side effects, psychological factors like depression, existential distress, altered smell or taste, general physical decline, isolation and lack of support. This is one important thing. Isolation and support is majorly seen in many patients in the palliative wards. and unappealing food presentation. So what we have to do is to manage the symptom, what symptom is exactly causing this anorexia, and to manage the dry mouth, oral issues, make food appealing. Even the patient is on rice tube, it is advisable to just point out, just dip the curry and touch it on the tongue. It will help. It will help to increase appetite. Make food appealing, psychological and social support, and educating caregivers. Education given to the caregivers is very important, especially in patients having dementia. Agni Devanam, Amapasam, these are the terminologies in Ayurveda which we try to. Padola Katarohinyadi, Vishwamardam, there are drugs too. So, to conclude, I would like to point out 2 points. One is integrative approach. So that is why we are all here. It's always good to have a proper integration. Integrative approach is the key thing to provide maximum benefit to the patient. No single system of medicine can provide complete relief to a patient. So that is what I believe. And holistic means you have to see the patient as a whole, not as parts and bits. You have to see the patient as a whole. This is an advice I want to give to the students. You have to see the patient as a whole and treat them, treat their mind. You enter their mind and treat. And the interconnectedness and interdependence is important by managing patients in the palliative sector. So this is what I have to tell. This is our institute, and together we can achieve more as a team. Thank you so much.